In our last chapter, we saw in chapter 10, the function of blood is to carry nutrients as well as oxygen and remove carbon dioxide and waste. And how it's able to do this is by the use of the cardiovascular system. So our cardiovascular system has two major components. We have heart and we have the vessels. And the function of this heart is to pump the blood. And as we allow that blood to be pumped, we exert pressure that forces these blood through different chambers as well as different vessels. The vessels in itself allow the blood to circulate throughout the different regions of the body, so we can have that exchange of oxygen and carbon dioxide at our lung level and also our systemic level. When we look at the vessels of our body, we have three major categories. We have arteries, capillaries, and veins. And any time you see arteries, always think of away, meaning that it's always going to be those vessels that go away from the heart. It can carry oxygenated or deoxygenated blood. Veins are the larger vessels that go towards the heart. And once again, can also be oxygenated or deoxygenated. Capillaries, this is where all that exchange occurs between our tissues and that nice nutriated blood, as well as nutriated and with all those oxygen as well. So capillaries is where all the exchange will occur. Now we're going to go over next video lecture the anatomy of the artery, the veins, and these different capillaries, but just want to introduce to you right now the fact that both arteries and veins can carry oxygenated and deoxygenated blood. So for the majority of this video lecture, we're going to go over the anatomy of the heart and as well as how the heart itself functions. So here we're going to look at two major vessels feeding into our heart, and this is going to be the superior vena cava and the inferior vena cava. So superior vena cava, this is going to carry deoxygenated blood, coming from our head, neck, and our arms. And here, inferior vena cava is going to bring all the deoxygenated blood from our lower body. And both of this blood is going to feed into the first chamber of our heart, and it's if you can imagine a cross section that looks just like this first chamber right over here, this is going to be our right atrium. And so both blood, deoxygenated blood, is going to feed into this right atrium. Now here you can see this large tissue mass here in pink. This is called the auricle. So it's an auricle is that tissue or mass sitting above that atrium, but it's not part of this chamber itself. It's sitting right above it. So I want you to be careful of this. If I ask you to identify the chamber on an exam, you want to mention that it's an atrium. However, if I point to the structure and this tissue mass above it, this is called the auricle. Now from this right atrium, where is blood going to go? It's going to enter into our second atrium, our second chamber, down here being the right ventricle. From our right ventricle, all this deoxygenated blood is going to enter into this region over here called the pulmonary trunk. Pulmonary, meaning lungs, means that now we're going to head towards our lungs. We want to exchange all that deoxygenated blood for oxygenated blood. So to do that, and of course we have both right and left lungs, we're going to direct this blood into each of those lungs. So here we have that right pulmonary artery. Artery, once again, meaning away. Pulmonary, meaning lungs. So this is that artery that's going to go away from our heart towards our lungs. That's this one over here. This one's going to be the left pulmonary artery going towards our left lung. We have all the gas exchange occurring within our lungs at that capillary bed, and then we're going to bring back all that oxygenated blood now back towards our heart using our left pulmonary vein and our right pulmonary vein. So vein going towards the heart, pulmonary being lungs, so it's the vessels that come straight from our heart going towards, straight from our lungs going back towards our heart. Now from our pulmonary veins, so both of these are going to feed into this next chamber over here, being our left atrium. So left atrium also covered by this left auricle. From here, we're going to cross into our next chamber, being our left ventricle. Okay, so let's just number them. 1, 2, 3, 4. So left ventricle, both of these are filled with oxygenated blood. From our left ventricle, we're going to bring all that blood into this ascending aorta. That's going to go through an aortic arc. And from our aortic arch, we're going to go down to our thoracic aorta and then our abdominal area and the rest of our body. Okay, so all this is going to be that nice oxygenated blood. There are other vessels that stem off of this ascending aorta. We have the right coronary artery, left coronary artery. From our left coronary artery, we have a branch forming the anterior interventricular artery. Anterior meaning the front, because we also have a posterior one. Inter meaning between the ventricles. Remember, we had a ventricle here and a ventricle here. So what are the function of all of these arteries? These are going to be feeding all the cells that comprise our cardiac muscle tissue. So of course, our muscle cells need to have nourishment, and they also need oxygen, and they need to be able to generate all that ATP for muscular contraction. Okay. So here's this nice cross-section of all the different chambers of the heart that we saw. Here's that interventricular region, so interventricular septum. Septum is a specific structure that's going to separate our right and our left ventricles from each other. Posterior to our pulmonary trunk, we can't really see it, but it's right over here. We have also an interarterial septum separating both our right and our left atria. Now let's clear this away, and let's see also how our blood can allow this one-way flow through the different chambers, and we can do that by these structures called valves. And if you notice, these valves are this nice cusp-like structure, so anytime blood falls back on it, it can catch it and prevent any blood from seeping through. So let's go through these different chambers and these different valves that separate these chambers. The first category we have are atrioventricular valves. Atrio, dealing with our atrium, ventricular, dealing with our ventricle. So this is the valves that separate both our atria and our ventricles from each other. We have the right atrioventricular valve and the left atrioventricular valve. So these are the valves. Now another term for your right atrioventricular valve is the tricuspid valve, because it has 3 cusps. Here, our left atrioventricular valve, also called bicuspid valve, has 2 cusps, as well as the third term being mitral valve. Now the second category of valves we have are the semilunar valves, and the semilunar valves are going to separate our ventricles from either a pulmonary trunk or our aorta. And so pulmonary semilunar valve is going to separate our right ventricle from our pulmonary trunk, so it's going to go towards our lungs. That's how we know it's pulmonary semilunar valve. And then down here we have aortic semilunar valve, being the separation between our left ventricle and our aorta. And once again, key term, we're going towards our aorta. Now there's another structure down here that I want you to notice and see, and this is called chordae tendineae. And those chordae tendineae are these string-like structures down here that are going to help anchor down as well as hold all of our atrioventricular valves. And the function of this, once again, is to anchor down, but it's called also our heartstrings. And during our heart relaxation, our chordae tendineae is going to be open and allows for that blood to passively come from our atria into our ventricles. And once our valves are closed, so it's once these valves close, so when it closes, it's actually going to this direction, like this. It can put and exert some tautness and some tension in the opposing direction to prevent any of these valves from falling back in this direction. So blood is going to fill this chamber over here, and it's going to put pressure along these valves in this direction. And so by having this tension and tautness from this chordae tendineae, we don't prevent any blood from entering into our chambers. Looking at this blood, we can have both oxygenated and deoxygenated. And so coming from our systemic circuit, coming from the capillary bed, entering into our superior and inferior vena cava, this is all going to be deoxygenated blood. And we see that here in blue. From our right atrium into our right ventricle, we're going to cross through this pulmonary semilunar valve. into our pulmonary arteries, being away from our heart, going towards our lungs. Here we have gas exchange, so deoxygenated blood. Now for oxygenated blood, we're going to go through our pulmonary veins because we're going towards our heart, coming from our lungs, enter into our left atrium. Left atrium and left ventricle going to have oxygenated blood. Left atrium is going to cross through this bicuspid valve, also called mitral valve, also called left atrioventricular valve, into our left ventricle, into our aortic semilunar valve, through our aorta into the rest of our body. Now we have the gas exchange again occurring within our body. You can put oxygenated blood into our cells and tissues and remove all that carbon dioxide and waste. And so I really want you to know and practice going through this entire illustration and then practicing which chambers are full of oxygenated blood and deoxygenated blood. And of course, that picture doesn't do our body justice. Anytime we see arteries and veins, anytime you see an artery, you're also going to see a vein adjacent to it, and you're also going to see capillary beds surrounding that transition between arteries and veins. And so in this illustration, you really don't see that well. But next video lecture, we're going to go through the different and major arteries and veins you're going to need to know for your third exam. Now, we're going to learn how exactly we can force all this blood through the different chambers to allow for this one-way conduction system from one area and one chamber to the other. And you can watch this video first before we get started so you can kind of get a sense of what we're going to talk about, and then we can watch it again after we're done. So here we once again have all that blood returning either from our lungs, that's going to enter into our right atrium, or from our body entering into our right atrium. So left atrium and then our right atrium. Now, a lot of times some students always find or think that each of these chambers are going to fill one at a time. But in actuality, both atria fill at the same time. They both pump that blood into the left ventricles at the same time. And they're going to eject blood out through that pulmonary trunk and into the aorta at the same time. So we're filling each respective side at the exact same time. Okay, so let's clear this out. So because we're going to start off with this atrioventricular valve, how this all fills, we're going to imagine that our ventricles had just contracted. We just pushed all the blood, and all the blood is now sitting here within our pulmonary trunk and as well as our aorta. So because we don't have a lot of blood in our ventricles, the pressure in our ventricles is going to be low. And also because of that, our ventricles are going to be relaxed. So low pressure and they're going to be relaxed. And because of that, all this blood coming from our body and coming from our lungs are going to passively fill from our atria into our ventricles. And because, of course, our ventricles are relaxed, all this chordae tendineae are also going to be relaxed. So here we see this passive filling from the atria to our ventricles, and here are those chordae tendineae. Now, at the end of this first phase, we're going to have arterial contraction, meaning both of our atria are going to contract. And this is going to happen when most of our ventricle is already filled with that blood. And once this atria contract, it's going to eject any residual blood from the atria into our ventricles. Now what's going to happen? Our ventricles are going to be at max pressure, so lots of high pressure within our ventricles because we're just forcing and we're trying to stuff as much blood as possible into our ventricles. Now, if any time you eat a lot of food, what happens? Your belly starts sticking out, right? Well, at least mine does. And that's because you want to exert and you want to allow all that pressure and all that to fill as much gaps and cavities as possible. So what happens here, it looks like only a bicuspid valve, but we have another valve over here. So I'm going to clear that off really quick. So here, these valves, because of this pressure, it's going to force shut these valves over here. So we're going to force shut both of these atrioventricular valves once all that blood is ejected into your ventricle. And of course, here are this chordae tendineae holding in place and ensuring the tautness of your valves that are there. Okay. Now that you have all this pressure generated into your ventricles, is your heart happy? No, we have high pressure here within our heart. And what's going to happen, we can start allowing stimulation down our heart muscle walls. And we're going to force then. Okay, so we're going to force, now that we have all that pressure within our ventricles, we're going to force that out. Our ventricles are going to contract, force that blood into your pulmonary trunk as well as your aorta. Now what's going to happen, and when you force that through, as you force the blood, you're going to also force open both semilunar valves, both your pulmonary semilunar valve and your aorta. And now you notice the anatomy of this, where our shape of our cusps are in this direction, so we can easily go through and force our blood in this direction from our ventricles to the next chamber, the next region. And what happens? Well, once we force that through, our ventricles are going to collapse or relax. And once our ventricles relax, what happens? We're going to then have lower pressure within our ventricles. All this blood here within our pulmonary trunk and aorta is going to fall backwards. Now here you notice that cusps. So semilunar valves. So those cusps are the semilunar valves. And once again, we have this nice design to catch all that blood that's trying to fall back towards your ventricles. And now, once again, this is how we can have that one-way flow of blood, and it's all because of the movement from our atria to our ventricles and the assistance of all of these cusps with semilunar valves and our atrioventricular valves collecting and catching this blood to prevent it from falling backwards. Okay, so for you, once again, you want to practice identifying not only the oxygenated blood and what chambers it's going through, you also want to know the vessels, and you also want to practice identifying these different valves. And one way we do this, especially during the school year, it's pretty fun activity. If you have color chalk at home, if you have kids or if you have cousins and you have color chalk, you can draw this image in figure 11.4, so this figure right over here. You can draw these major arteries and veins. You can draw lungs, and you can draw the heart, and just practice walking through it. So practice walking and identifying each of the different chambers as you walk through the vessels and also the chambers. And also practice if you're oxygenated or deoxygenated. Now that we saw how the blood flows from our atria to our ventricles, let's see what exactly triggers that contraction of our heart to move that blood. And so we have two different types of cells that comprise our conduction system for blood movement. We have nodal cells and we have conducting cells. The first category of nodal cells, this is considered our pacemaker cells. So it's going to set the pace of our heart rate. And we also have the conducting cells that receive all the stimuli through the form of electrical impulses from our nodal cells to allow and disseminate that signal through our entire ventricles and allow for that contraction. And so we can distribute that stimuli towards our myocardium. Here's an overview of all the different components. We have the SA node called the sinoatrial node. We also call this the pacemaker of the heart, so this is where that signal stems. We're going to spread that signal down the walls of our atria to have coordination of contraction of our atria. We're going to receive that signal down here at this atrioventricular node, or we'll also call the AV node, so atrio and then ventricle. And that's also going to be found here within our right atria, or well, actually right between right atria and our right ventricle. And we're going to bring that signal down here through this atrioventricular bundle of His. Spread that down through our bundle branches and allow that to spread through our myocardium through this Purkinje fibers. Now, both our atrioventricular bundle or bundle of His and our bundle branches, these are both found within that interventricular septum. So now let's go step by step and see how we can have this conduction occur from our SA node all the way down to Purkinje fibers. So the very first start, we're going to generate an impulse at our SA node, and we want to spread this towards our AV node. So this is number 1, and we want to get to number 2. And so we have that stimulus from our brain that's going to cause our SA node to fire off. We're going to spread that electrical impulses down this entire wall of both of your atria. Once it reaches our atrioventricular node down here, this is going to allow, and what signals and culminates at the end of this is our atria are going to contract. So all of this have been stimulated. we now relay that stimulus down here. At the end of that, we're going to have atrial contraction. And so as a little reminder, what happens at atrial contraction, we're going to eject all that blood here within our atria, all that residual blood, and force that down into our ventricle. Now, third thing that happens, once we receive that signal here at our atrioventricular node, we're going to carry that into our bundle of His, down to our bundle branches, and then spread that down into our Purkinje fibers. The moment we spread that to our Purkinje fibers, what's going to happen? We're going to set off those action potentials, causing depolarization of our heart muscle cells. And then what happens? You get depolarization, you have contraction. So now you're going to have contraction of all of this cardiac muscle tissue at the exact same time. So when that happens, you're going to culminate with your ventricular contraction. So both of these ventricles are going to fire off and contract, and what's going to happen to that blood? It's going to get ejected into your pulmonary trunk and into your aortic semilunar valve. And then what happens after that? All that blood, once it's ejected through, it's going to relax. Your ventricles are going to relax, and all that blood's going to fall back towards your semilunar valves. Okay, so here are those events one more time. You're going to initiate that pace of your heart by this SA node. We're going to have spreading of that depolarized or the polarization of those electrical stimuli, spread that electrical stimuli through both walls of your atria. Once it reaches at this AV bundle or AV node, we're going to have a slight delay, and then we're going to have both atria contract. Once that atria contract, this is when we're going to force that residual blood into your ventricles. And once that happens, then we're going to conduct and spread the signal from that AV node down our bundle of His and also our bundle branches through our interventricular septum, out through your Purkinje fibers. And once we spread it down to your Purkinje fibers, we're going to depolarize all that cardiac muscle cells and tissues, and then we're going to have ventricular contraction. After ventricles relax, after we have that ventricular contraction, our ventricles are going to relax. And if you remember, our cardiac muscle cells, you remember that they have this nice branching structure. And also we have those intercalated discs being those gap junctions. And this is how you have this nice coordination of your contractions, because of these intercalated discs that are really whole. So it looks like nice long lines, but they're actually holes and gap junctions that allow all that calcium to go through to all of these heart muscle cells. And by allowing all this calcium to flow through very fast and very easily through your heart muscle cells, and then we can have that coordination of contraction, right? So you want that quick, fast region, coordinate all this heart muscle cells to contract at the exact same time. So here are a couple more videos to help you look at the intrinsic conduction system of the heart, as well as contraction of the heart. So I'll post those also on your weekly assignment page. Now, let's look at two other terms, and also how we can describe our cardiac cycle. And also, whenever you hear your heart beat, you also notice that your heart's going to give rise to lub-dub noises. So we'll see what those are caused by. And so here, once again, both atria are going to contract at the same time, and both atria are going to relax at the same time. Then your ventricles are going to relax, and they're also going to contract, and then they're both going to relax. Anytime we deal with contraction, whether it's going to be your atria or your ventricles, we all call it systole. Anytime we deal with relaxation, we call it diastole. So the very first thing we're going to look at is cardiac cycle, the different phases of diastole and systole. So here we have first mid to late diastole, meaning we have that relaxation. So this is during that relaxation phase. pressure in our heart, both atria and ventricles are going to be relaxed. And once again, pressure in the heart is low. So because of that, we have that nice passive filling from our atria into our ventricles. So once we do this, our pressure in our heart is low. At the end of this, remember, our SA node is going to send that signal down to our AV node, down over here. At the end of this, our atria are going to contract. So when our atria contracts, we're going to force that blood into our ventricles. Second phase we have then is, so one step back. The end of mid to late diastole is going to culminate in our arterial contraction. Now, what happens after our atria contract? We're going to eject all that blood into our ventricles. At the very beginning of ventricular systole, so now this deals with ventricles contracting, what happens? Remember, we're going to force all that blood back towards our atrioventricular valves. When this shuts, that's going to make a noise. So the very first heart sound that you hear, that lub-dub, 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 that lub is due to the closure of these atrioventricular valves. And that's when that blood's going to force upon them. Now, what's going to happen? When this occurs, after our ventricles, after our atria contract, our atria are going to be relaxed. So this is the very first phase of that ventricular systole. Second part of ventricular systole deals with the contraction of our ventricles. And so now with this high pressure, our ventricles are going to contract and then force that blood into your pulmonary trunk and your aorta. Now we have this third phase of this cardiac cycle being the early diastole, so early relaxation. And for a brief moment now, our ventricles, after they've contracted, they're going to relax. So the pressure here within our ventricles is going to be low. And because of that, we're going to have relaxation. And all this blood, both in our pulmonary trunk and our aorta, is going to fall backwards, going to get caught by our semilunar valves. Now, once that happens, we're going to close shut both of these semilunar valves. And that's going to give rise to our second heart sound, being that dub. So lub-dub, lub-dub, lub-dub. The first lub is closure of your atrioventricular valves. Second sound, being the dub, is being the closure of the semilunar valves. Okay. Now we're going to start the cycle all over again. So make sure you understand this mid to late diastole, ventricular systole, and early diastole, as well as what gives rise to the different sounds of your heart. So you can watch that video over here once more. Last thing we're going to look at is cardiac output. So measuring the amount of blood pumped by each side of your ventricle of the heart in 1 minute. And you can also look at stroke volume, which is the amount of blood pumped by each ventricle in one contraction. Both of these are fairly consistent unless you are working out, unless you're in a stress situation. Typically for stroke volume, it's 70 milliliters out of the left ventricle with each heartbeat. And your heart rate on average is 75 beats per minute. So 60 to 100 on average. And of course, if you work out a lot, this is going to be much lower. Now, how do we calculate cardiac output? You're going to look at your heart rate versus your stroke volume. So if you have a heart rate of 75 beats per minute, your stroke volume is 70 milliliters per beat, both this numerator and this denominator are going to cancel out, so your cardiac output is going to be about 5.25 liters per minute. And how do you change your cardiac output? Well, you can change it by changing your heart rate. So changing this factor over here. And so cardiac output on average 5 to 8 liters. But of course males much larger compared to females. They have larger of those organs. So let's see how we can adjust that heart rate to change that cardiac output. So a couple things here. If you want to stimulate your sympathetic nervous system, remember that fight or flight. How do you do that? Well, if you are in a stressful situation, you want to increase your heart rate thereby delivering all that oxygenated blood towards your cells and tissues. If you have low blood pressure, you also want to increase it, so you're going to stimulate your sympathetic nervous system. Or if you also have high blood pressure, high blood volume, that in turn is also going to have this high amount of heart rate. Hormones, epinephrine, we saw that in chapter 9, increasing your heart rate. And then also here your parasympathetic nervous system, this is actually going to decrease it. So so this is going to decrease that heart rate. So these are different factors that give rise to changing that cardiac output. Stroke volume also being another factor to change cardiac output, because remember heart rate, oops, there goes my battery again. Heart rate versus stroke volume times stroke volume, both going to give rise to your cardiac output. So exercising a lot, this is going to increase and also increase your stroke volume. Decreasing your blood volume, so if you're bleeding, that in turn is going to decrease the amount of circulating blood, and therefore decreasing the stroke volume, and therefore decreasing the amount of blood that's going to be pumped out of that heart. Now, a couple of homeostatic imbalances, ischemia. This is if you have a lack of oxygen to your heart muscle tissue, and therefore your heart muscle tissue might start dying, and that's going to give rise to the inability for your heart to contract. Fibrillation, we know this as shuddering, so those quick, fast shuddering and contractions of your heart, and they're not coordinated. Sometimes if you drink coffee and you're stressed out, this can give rise to that fibrillation. Tachycardia, this is if you have over 100 beats per minute, so very high, fast heart rate. And this doesn't necessarily mean a bad thing. So when you work out a lot and you're running, your heart's going to be in the state of tachycardia. Bradycardia, this is when it's less than 60 beats per minute. So when you're sleeping, or if you work out a lot, you're going to have a lower heart rate. That's it for the first part of chapter 11. I'll see you in the second part.